Hello, and welcome to JAMAevidence, our podcast series based on core issues in evidence-based medicine. Today, we will be discussing interim analyses during group sequential clinical trials. I'm your host, Dr. Roger Lewis, Senior Statistical Editor for JAMA and editor of the JAMA Guide to Statistics and Methods series. I'm here with Professor William Meurer. Dr. Meurer, can you go ahead and tell our audience a little bit about yourself?
My name is Will Meurer. I'm a professor of emergency medicine and neurology here at the University of Michigan in Ann Arbor. My research focuses on the early care of neurologic emergencies such as stroke, coma after cardiac arrest, and traumatic brain injury.
Great. Thank you so much for joining us. So in your article, you talk about a technique for analyzing a clinical trial while it's being conducted. And that type of clinical trial is called a group sequential trial. So let's start by having you explain to us what is a group sequential trial.
So in this type of clinical trial, the patients are enrolled in groups, and there is analysis after each of those groups is enrolled.
So those analyses after each group of patients are commonly called interim analyses. So what is an interim analysis, and what kind of conclusion might you draw at each one of those analyses?
So, an interim analysis is any type of analysis that is taken while a trial is ongoing that potentially leads to a conclusion before the planned maximum size of that trial.
So why do we do interim analyses? Why don't we just conduct the clinical trial to the maximum sample size and then analyze the data and draw a conclusion?
So, a lot of times when we start out designing a clinical trial, we have a fair amount of uncertainty as to how well a treatment will work, or maybe how well patients will do when we enroll them in a more controlled environment like a clinical trial. With that uncertainty, we do still have to arrive at what we're going to invest, how many patients we're going to have in this next trial. If we're off in our assumptions and we don't get it exactly right, then our trial may be way too big or way too small for what the biological truth we're looking to find is. Like, how well does this treatment work? Interim analysis is a way to use information that's accrued within the trial in a systematic way to come to a conclusion earlier.
So what does one actually do at one of these interim analyses?
Usually, there are unblinded study staff, often statisticians, who have access to the data by treatment group, whereas the people who are doing the enrolling in the clinical trial and the clinical principal investigators do not have access to how the treatments are doing compared to each other. This unblinded individual or team looks at the data and applies some statistical test to it to make a conclusion as to whether the trial should continue and whether more groups of patients should be enrolled.
So the trial is ongoing, and partway through the trial, we take a look at the data and perform some sort of statistical test. What are the various results of those statistical tests, and what kind of actions might be taken?
Commonly, those statistical tests are either looking to see if the trial is extremely efficacious. One of the treatments is far superior to the other. For those who use frequentist statistics, this would be a very low p-value, like p of less than 0.001 possibly. So the interim analysis may be oriented towards finding a very low p-value that shows you that the treatment is really overwhelmingly effective. On the other hand, it may be that you've designed a trial of, say, 1,000 patients, and the treatments look so similar at this point that there is no way that they are going to separate by 1,000. That would be an analysis for futility. Again, it would let you know that within what you think is a reasonable treatment effect, there's really no way that you're going to find a difference by the end of the trial. So if you've enrolled 500 out of your 1,000, you can already draw that conclusion that there isn't going to be a large difference between those groups in all likelihood.
So let's focus on the more optimistic possibility that the treatment works better than we anticipated. And so partway through the trial, the data start to suggest that we could stop the trial and conclude that there was a treatment benefit. What are the risks associated with drawing that early conclusion?
So when you do an interim analysis early, you're taking another look at the data. And every time you look at the data, there's a risk that you could draw a false conclusion. This is one of the forms of multiple comparisons. So by taking this additional look, even if it's just one additional look, you do put yourself at risk of having another opportunity to erroneously declare a neutral treatment as a good treatment.
So, if taking interim analyses can increase your risk of a false positive result, what can we do to control that risk so we can really trust the results of trials that stop early?
Before I answer that, I need to describe what alpha is. And this is also known as the type 1 error rate of a trial. And basically, this is this idea that with any statistical test, sometimes we pick up the noise as opposed to the signal. And it is the risk, if the trial had been repeated multiple times, that even when there is no difference and the treatments are the same, you falsely conclude that the trial is positive. So basically, the false positive likelihood for a trial that is repeated multiple times. So there are statistical techniques to account for the multiple comparisons. Broadly speaking, they allow the team that is designing the trial to come up with thresholds for declaring success that are harder to achieve than they would be for the entire planned maximum sample size. Sometimes these things are known as alpha spending functions. So if you have, say, a overall p-value of 0.05, which is commonly seen in a lot of statistical tests and studies, you could consider that 0.05 all of your alpha, and perhaps you would spend only zero point zero 0.01 of it at your first interim analysis, and then you would have zero point zero 0.04 left at your last. In a very sort of simplistic way of spending alpha, that is one way to look at it. As many of you have done other statistical tests, you're familiar with things like a Bonferroni correction. When you do multiple comparisons, you divide the alpha by the number of comparisons. This is basically a subset of that that is set up in such a way to preserve as much of the alpha for the end as possible so that you still have most of the power of your trial.
So, Will, one of the things that you mentioned is that when you design a clinical trial, there's often tremendous uncertainty in the true treatment effect. And that makes it really difficult to make the trial the right size. So, obviously, if the treatment didn't work as effectively as we might hope, we would need a larger trial to demonstrate its benefit. And if the treatment worked really well, we would have a smaller sample size that would be adequate to demonstrate the benefit. So, how is it that the interim analysis plans in a group sequential trial address that issue?
Having an interim analysis plan with the possibility of stopping early allows you to potentially have less sadness at the end of your trial. And by this, I mean you may have some difference between these groups that you think could happen if you're very optimistic and the treatment works really, really well. As scientists, we often tend to be optimists and say, I really think this new treatment I've developed is going to work really, really well. However, it might not work quite as well as we like, but even perhaps if it worked half as well, we would still be excited and it would still be a great treatment. By building in interim analyses, the trial can kind of address both of these situations in a way that is pre-specified and potentially efficient, in that if my really optimistic view of a large treatment effect comes out, the trial is set up to end early and those results can be declared. But if I would have been sad to have missed that treatment effect that was maybe half as big but still very relevant, then hopefully I can design the trial with that interim analysis so it can continue if it needs to show the world and other investigators and patients that that smaller treatment effect is there.
So, essentially, it addresses your uncertainty in what the right size of the trial is by allowing you to have a design that ends up with the right size population, regardless of what the treatment effect turns out to be. Is that fair?
That's fair.
So, when a trial is stopped early because there's evidence of overwhelming benefit of the experimental therapy, obviously you have less data to work with than you would have had the trial continued to its maximum sample size. So, doesn't that create other problems, for example, in estimating treatment effects or evaluating subgroups?
It can make the evaluation of some subgroups a little harder because you will have fewer patients assigned to those subgroups. However, if the treatment is efficacious, it's unlikely that that overall conclusion that the treatment is efficacious is going to be altered by these small differences. And it's important to the people who are outside of the trial to learn of this and get access to a potentially important new treatment.
Now, I've also heard concerns regarding the possibility that trials that stop early overestimate the true treatment effect, that they're overly optimistic, if you will.
While that is a theoretical concern and likely exists to some degree in clinical practice, from the perspective of most of the treatments that we're testing in large scale clinical trials, it's unlikely to be relevant to us as clinicians as to whether we should be using a new treatment or not. Another way of thinking of that is that while statistically the treatment effect that we observe in such trials that are ended early may be a little higher than the truth, it's really unlikely that that's going to lead to a difference that's clinically meaningful or would change whether or not clinicians should be using the new treatment.
Now, in your article, you mentioned this study by Locatelli et al. Can you tell us a little bit about what they did and how they used interim analyses in their study?
Yeah, so they were doing a study of a new antibody for relapsed leukemia in children. And in the study, they were planning to enroll a maximum of 200 patients. And they were looking for some number of events, which were basically recurrence of the leukemia or death, to occur, basically hoping that this new treatment had a more favorable effect on reducing recurrent cancer or relapse of leukemia than the standard chemotherapy for that situation. And they designed the trial to have that maximum sample size of around 200 patients, but they also built in interim analyses at 50% and 75% of information. In this case, because they were doing survival over time or a time to event analysis, they were looking to see that a certain number of events accrued in the trial. When they reached 50% of the expected events, they conducted an interim analysis to see if there were difference between the treatment groups. What they found was there was a large effect in favor of the new treatment over the standard chemotherapy. At that time, they were able to declare efficacy of this new regimen and share that with clinicians and patients everywhere.
Will, you mentioned that the interim analysis has to be conducted by a team that's unblinded to the data, meaning they know explicitly the treatment assignments and the outcomes of the patients separated by the treatment arms. We also want to keep the investigators blinded to the treatment assignment to avoid introducing bias in the trial. So, who gets to see the results of the unblinded interim analysis, and how do we advise the investigators without prematurely or inadvertently unblinding them to the trial?
So the unblinded statistician will provide the unblinded data to the Data Safety Monitoring Board, who's reviewing it over the course of their oversight of the trial. If there was an interim analysis that recommends stopping due to crossing of one of the boundaries or rules, then the DSMB would provide a recommendation to the investigators to stop the trial.
So, when they provide a recommendation to the investigators to stop the trial, does the DSMB tell them why, and isn't that unblinding?
It is partially unblinding. In most cases, the DSMB is going to provide at least the context as to whether it was for futility or for efficacy.
So, well, what are the key takeaways from your article for our audience?
I think first is at the beginning of a trial, as we're planning it, we don't really know how big it should be. And by building in interim analyses, we protect ourselves, our patients, and to some degree science from the possibility that we either make our trial way too big or way too small. A second important consideration is by having the ability to stop early, if we have really already reached a conclusion that a treatment is effective or it's not going to be shown to be effective by the end of this trial. It's really important to get that information out there so that the patients can know that, other clinicians can know that, and other researchers who may be thinking about doing a trial in a similar space can also know that. Finally, there are concerns that when trials stop early, that there is some bias associated with the estimate of the treatment effect or how well that treatment works. And I think it's important in the types of conditions that we generally study in clinical trials that potential statistical bias is very unlikely to be clinically relevant and change our conclusions as to whether the new treatment is better.
I am Roger Lewis, and I've been speaking with Professor William Meurer about interim analyses in group sequential clinical trials. You can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at JAMAnetworkaudio.com or search JAMA Network wherever you get your podcasts. This episode was produced by Daniel Musisi at the JAMA Network. Thanks for listening.